So my name's Dan Loveman, I'm the director at Turning Point, and pleasure to invite you to this month's Talking Point. Just before we start, I'd like to acknowledge the traditional owners of the land on which we stand, the Wurundjeri people, and pay my respects to elders both past and present. So this month we've got a great speaker, as we do every month, Dr. Adrian Carter, who's a senior research fellow at the School of Psychological Sciences at Monash University, and I've known Adrian now for a long time. So Adrian initially did his PhD up at the University of Queensland with Professor Wayne Hall, who many of you may know, who's an eminent figure in the field of addiction, particularly with a big focus on policy and policy impact of addiction, and looking at how different policy measures have impacted on a whole range of different harms and how they've been effective or not effective. And really, Adrian's picked up that mantle and really particularly focused on the area of neuroethics. So, look, as you know, many of you will be aware, there's a whole boom around the issue of sort of how the underlying neuroscience of addiction, sort of what happens in the brain, and really what promise that holds. And Adrian will talk a bit about what has been promised, I suppose, in this age of investment in neuroscience and how that might influence public policy and perceptions in the community. And I think Adrian's going to tell us a bit about sort of what the evidence actually shows and whether it's worked or hasn't worked. So I'll just introduce Adrian to come and join us, I think.
Thanks, Dan, and thanks, Victoria, for inviting me to come and talk to you. It's a real pleasure, and it's great to see so many people. Clearly, everyone's interested in this sort of neuroscience research on addiction and what it might mean for treatment. As Dan mentioned, I work in an area that's called neuroethics. So we're looking at the ethical and policy implications of neuroscience research on addiction. Most of this work I've been doing with Wayne Hall over the past sort of 8 years. If you're interested in any of this, I'd say recommend you sign up to or join our Twitter feed at neuroethicsau. Or you can follow us at the Centre for Excellence in Integrative Brain Function, where I run the neuroethics program there, and you can find out more details. Okay, I'll just give you a very brief overview. I'll introduce what neuroethics is, because I understand that's probably a term that's not overly familiar to a lot of people. I will then review the neuroscience evidence. So, what is the evidence that that addiction could be reasonably thought of as a brain disease? I'm sure we've all heard that sort of notion being bandied about in recent years. And then I'll talk a little bit of research we've been done looking at Australian clinician and neuroscientist views before examining some of the claims that are being made. So a lot of sort of social and policy benefits that have been put forward by its proponents around improved treatment and prevention, as well as reduced stigma and more humane treatment. I'll examine whether the brain disease models lived up to that promise. And then I'll talk about some of the potential policy misuses of this way of thinking about addiction. And hopefully, at the end of it, I might be able to propose a way forward where we can sort of take on the insights from neuroscience with perhaps avoiding some of these pitfalls. So what is neuroethics? William Safire, who was once speechwriter to President Nixon, defined neuroethics as the examination of what is right and wrong, good and bad about the treatment of, perfection of, and welcome invasion or worrisome manipulation of the brain. I find that a little bit hard to understand, so I go for something a little bit more simple. The translation of neuroscience research into effective, ethical, and efficient clinical treatments and public health policies. The work that we do is deliberately anticipatory and proactive, so we don't want to wait until potential negative things happen. We want to try and look at how might neuroscience be used, look at history, what can that teach us about some likely outcomes, and try and prevent them. The analysis of public policy and ethical implications for addiction, that specifically looks at how does neuroscience change the way that we think about addiction, what sort of control people have over their drug use, and how we think about people with an addiction. Are they morally bad? Are they diseased? What does this sort of research tell us? And this has implications for how we treat addiction, what sort of treatments we think are appropriate, as well as the sort of questions we want to ask when we do research around addiction. It also has, I guess, more philosophical implications around free will. So if addiction is a result of neurochemical changes in our brain, what does that say about our ability to make free and autonomous decisions around drug use? I won't be talking so much about that. It's getting a little bit further out of our area. We tend to focus on, I guess, more pragmatic and practical things that we can learn. Just quickly, ethical analysis and policy analysis involves asking two questions. The first is, can we? So what does the science tell us about addiction? What does it tell us about the way that it impacts on people's brains, or new treatments that might emerge? How safe and effective are they? We also want to look at whether this is something that is practicable and affordable. But just because we have evidence that we could do something doesn't mean that we should. So then we then look at whether something is ethically acceptable. There are lots of different ethical theories out there, but I tend to use one that's quite popular in clinical medicine, which is called principalism, which involves 4 ethical principles. The first one is respect for autonomy. This is sort of the main principle that underpins human rights. We want to try and, does a policy maximise people's freedom or liberty? And this has particular implications in drug addiction, where people may be impaired around decisions about making choices around their drug use. They also might be vulnerable individuals, so we then have an obligation to protect these individuals. 2 principles you're probably more familiar with, beneficence and non-maleficence. So this is the Hippocratic Oath: do good and don't do any harm. So are treatments or policies likely to be safe and effective? And finally, the principle of justice, which is probably the most difficult to understand and to try and negotiate. Are the benefits and harms of a policy or an intervention fairly distributed? We don't want to introduce policies that may be effective at reducing societal harm, but they unfairly burden a particular individual, particularly if they're a vulnerable individual who may be coming from an environment where they have less social choices. So that's just sort of an ethical framework. Quick plug. So this is work that we published in a book in 2012 with Cambridge University Press called Addiction Neuroethics. It's a few years old now. But more recently, we updated this for a paper in Lancet Psychiatry, which we make the same arguments, and it's you can probably download it for free, and it's a much shorter read, so probably I'd go there. And also it'll help with our citation counts. But and so we've all probably heard that the claim that addiction is a chronic and relapsing brain disease. This sort of emerged from a seminal paper written about 20 years ago by the then director of the National Institute of Drug Abuse, Alan Leshner, who famously said, addiction is a brain disease and it matters. So in this paper he was outlining not just the scientific case, like what the evidence was that addiction could be thought of as a brain disease, but the social implications, so why this was going to be good for addicted individuals and for society. In it, he argued that the chronic use of addictive drugs produces changes in the brain that drive people to drug use. Later, NIDA researchers have gone further and said that people with an addiction have been hijacked by their drugs, so they no longer have the ability to freely choose not to use them. And this view is consistent with a number of clinical observations. So basically the fact that we know that addiction tends to be a relapsing disorder, and the rates of relapse are quite high. When they talk about a disease, though, they're obviously not thinking about sort of more pathological, infectious diseases. They're thinking about lifestyle diseases, such as diabetes. So the evidence for the brain disease model of addiction comes from several lines. First is the genetic evidence. So we know that addiction is a highly heritable disorder. And genes are thought to account for about 40 to 60% of the risk in developing an addiction. Geneticists have identified a number of candidate genes that are thought to explain this increased risk. Some are protective, some increased risk. All might be aware of the alcohol metabolism genes that are more prevalent in Southeast Asian populations. So these genes interfere with their ability to metabolize alcohol efficiently, and they can develop very aversive physiological responses such as flushing, nausea, headaches. And this is actually preventative, or protective against developing an alcohol dependence, because it's obviously you have to work a lot harder to become dependent if that's the sort of experience you're getting. The second area are animal models of addictive behaviour. We know that animals will repeatedly self-administer all the drugs of abuse that humans tend to get drug addicted to. They'll also learn to associate the administration of those drugs with particular areas, so they'll spend time in areas where they've previously been exposed to drugs of abuse. And they've also identified the what's called the dopaminergic reward pathway. And you can see here this animal's got an electrode inserted into the nucleus accumbens, and he's just sitting there pressing on a lever which is delivering an electrical stimulation. So through these experiments they were able to sort of identify the parts of the brain that are thought to underpin motivation, to make us want to do something. Then we've got the human neuroimaging studies, and through using sophisticated brain imaging techniques we've been able to confirm many of the changes that we see in animal models, we also see in human models. So they'll do a study where they'll image a group of people who don't have an addiction and compare the changes to a group who do develop, who have been dependent on drugs. And just a couple of examples here, you can see someone who hasn't used cocaine or is not dependent, and then a cocaine abuser, and you can see there's a downregulation of dopamine receptors within the reward pathway of the brain. Similarly, this is a study looking at the what they call the orbitofrontal cortex, and the person with the cocaine abuser seems to have less activity in that region, and that's thought to be illustrative and an impaired ability to control impulses to use drugs. And many of these changes we know persist beyond abstinence. This is a contentious area because some people would argue that these changes are permanent, whereas others have sort of found that if people are abstinent over time, they can reverse some of these changes. We also have evidence from neurocognitive studies. We know that people with an addiction have a number of impairments to memory, learning, and impulsivity. And there's a whole suite. I just chosen one example, which I quite like. This is a study of reward learning. Basically, people are given two types of decks of cards, some that have small rewards and small losses that they choose from, and others that have very large rewards but even larger losses. And over time, most people learn, they might pick the one that has the large rewards, but over time they'll realise that they'll lose a lot more money, so they switch to the less rewarding deck. This graph here illustrates that over time, this is the sort of learning to go for the low reward, low risk deck. People with a substance dependence have an impaired ability, and these are people who have lesions to the ventromedial, so that orbitofrontal cortex part of the brain, and they are unable to learn. They just keep on going for the big wins. So that's just one example of an impairment that we see. We also get insights from an unexpected area. This is from people with Parkinson's disease. So Parkinson's is a neurodegenerative disorder, which is the loss of dopamine cells, so they have to take a dopamine replacement therapy to account for this. And about 1 in 7 will develop a compulsive disorder, so pathological gambling, hypersexuality, compulsive eating. And this further strengthens the view that the overactivation of dopamine in these regions can drive addictive behaviours. However, there is some evidence pointed to by what we'll call the brain disease skeptics, and most of this comes from epidemiological evidence and observational studies where they've looked at the behaviour of addicted individuals over a long period of time. And we know that, in fact, most people actually mature out of addiction. Most persons who have met a diagnosis of addiction during their lifetime aren't dependent at the time of their interview. And in fact, most people will quit without assistance, and this is particularly true around smoking. The method that most people stop smoking is just going cold turkey. We also know from the studies of the US returning veterans from Vietnam, about a third developed severe opioid dependence while they were over there. However, when they got back to the States, many were able to stop using opioids without seeking treatment, even those who did consume some opioids when they got back to the US. We also know that most adolescent drug users will mature out of drug addiction as their sort of their lives changes. They get jobs, they get families and mortgages. So contrary to this view that addiction is a brain disease that people don't recover from, cessation is actually the norm. We also have evidence from the fact that drug use appears to be price sensitive. So we know that if we increase taxes on cigarettes or alcohol, this reduces drug use. And this is true even in the most severely dependent individuals. This is why the government, one of the reasons why the government puts up the prices on cigarettes and alcohol. We also have evidence from an area called contingency management. And this is where researchers will provide small financial inducements for people not to use drugs. And we know that even very heavily dependent individuals will reduce or stop using drugs in response to these small financial incentives. And there was a study in Scotland where they looked at pregnant women who were smokers, and they gave them quite a small financial reward, and they found that they were able to reduce or eliminate smoking in these pregnant women while they were carrying the baby. And this had a really massive impact on the birth of the child, so more babies made it to term and their birth weights were heavier. So this was a really significant social outcome. And both these facts are kind of incompatible with the view that addiction is a brain disease that have been hijacked by neurotransmitters in their brain and they can't control their drug use. Clearly, given the right social circumstances, people do maintain the capacity to control their drug use. So how do we reconcile these two worlds of addiction? First, I think we acknowledge that addictive, and I'm sure this is completely apparent to all of you, addictive disorders vary greatly in severity. Mild to moderate disorders are quite common in young adults, but the majority of people will mature out of these addictions in response to marriages, mortgages and children. There will be a minority for whom recovery will be more difficult, and their condition becomes more chronic and will cause more harm to themselves and to the others. But this is a vast minority of that population. And this has important implications for how we talk about addiction. The proponents of the brain disease model can't really use the lifetime prevalence of addiction rates as estimates of the severe chronic addiction as described by the brain disease model. Often when they talk about these conditions, they'll talk about, this is the prevalence of addiction, and then imply that applies to all people who have this sort of chronic relapsing brain disease. It's only a small fraction who could possibly be thought of as having a chronic and relapsing brain disease. We look at who develops the chronic addictive disorders. We know that they tend to be antisocial males. They tend to be people who start using drugs earlier and have a lot of drug-using peers, maybe family exposure to drug use. They tend to come from poorly educated backgrounds. They tend to have fewer relationships and fewer life choices. And also those who tend to self-medicate, so those who have other comorbid psychiatric disorders. So even if we do accept that there is a small percentage of the addicted population for whom you might think of as having a chronic and relapsing brain disease, how compelling is the neuroscience evidence to support this? So we went through the evidence and looked at each of the different areas I talked about before. And animal models provide a poor model of human addiction. I mean, it's obvious to say that there's great social and cognitive differences between rat models and humans, but there are also some other important difficulties. It can actually be really difficult to get an animal addicted, particularly to a drug like alcohol, and they have to use specially bred rats to try and, which they use in these experiments. They're also conducted in highly controlled environments, and there's been a number of studies that found that when you put a rat in a more naturalistic environment, what they call enriched environments, where animals have access to other things like exercise wheels, litter mates, that we don't see the same sort of self-administration of drugs. They will make other choices. And I wonder whether this says something more about the social environment. So, if people don't have other choices or access to jobs, employment, relationships, are they more likely to engage in drug use? So maybe this tells us more about the social environment than it does about people's brains. The genetic evidence also isn't as strong as some people would suggest. There seems to be a large number of risk alleles involved, so hundreds of genes have been identified that seem to play a role in addiction, but each of these genes plays a very small role in increasing someone's risk. So in genetic research, they'll talk about odds ratios. And so having a particular risk allele may increase your chances by about 1.2. I mean, that is insignificant if the prevalence is, quite low. The neuroimaging and neuropsychological evidence isn't quite as compelling as some proponents would think as well. Johnny Ioannidis, who's been a constant irritant to a range of scientists. He doesn't pick on just neuroscientists, but he picks on also the biological sciences, and he examines their studies. And he did one study looking at neuroimaging and neurocognitive research and found that the majority were underpowered, which means that the sample sizes were too small to be able to be certain about the results being a true finding. And he estimated up to 80% of these could be false positives, which may explain why there's an epidemic of failure to replicate in a lot of these small studies. Studies will tend to use very small sample sizes, 12 or 15 individuals, mainly because they're very expensive to run. There are some great initiatives worldwide where people are starting to bring their resources together and to start looking at these hundreds and thousands, and these are starting to produce some more useful and informative resources. And Dan Lubman's been quite involved in some of the efforts in Melbourne and elsewhere. Another important fact or point to note is that these demonstrate group averages or trends. So as I mentioned, when you see the brain image, that's not one person's brain. That is an average of a lot of individuals' brains put together. And we know that while some addicted individuals will show these deficits or changes in brain function, not all. And some of the non-addicted individuals will have these deficits. And it's also not possible to tell from these studies whether the changes are a cause or a consequence of drug use. So has the chronic drug use caused these changes in their brain or their cognition? Or are these differences the things that have helped or made it more likely for them to end up taking drugs and becoming addicted? Again, there are some prospective studies, so studies looking at early adolescence, so before people have started using drugs, which will start to be able to disentangle some of these questions to look at what preceded, the brain changes or the drug addiction or drug use preceded. And the fact that we see some changes in brain function doesn't mean that people are unable to refuse a decision about an offer of using their drug. It doesn't mean that their choice is involuntary, only that it's possibly more difficult than for someone else who's not used drugs. We next want to sort of look at what the consensus view amongst clinicians and neuroscientists is around the sort of brain disease view. The American Society of Addiction Medicine released a policy statement redefining addiction in 2011 or 12, I think. 11. In it, they said, drug addiction is a disease. Images of the brains of addicts show alterations in regions crucial to learning and memory, judgment and decision-making, and behavioural control. None of that is particularly controversial, at least among scientists. In 2014, there was an editorial in Nature which ran a similar line, and they said that addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. The emphasis on primary. But we wondered whether, is this something that's held by a lot of people? Unfortunately, there's not a lot of empirical evidence that we can look at for these claims. In response to the editorial in Nature, there was a group of concerned addiction researchers who signed a petition saying that not only did they think that addiction wasn't just a brain malfunction, that it might be harmful to suggest that. And that was signed by 94 leading addiction researchers, led by Derek Heim, who's actually putting together a group of people who might come together to kind of counteract this view that addiction is a brain disease. We thought we'd look at what Australian addiction clinicians and neuroscientists think. We interviewed 31 addiction neuroscientists and addiction clinicians, a range of people working within the field. So we had animal researchers, cognitive neuroscientists, psychologists, addiction physicians. All the people we spoke to were actually involved in addiction research. So these are people who are going to be very informed, and you would think would be more partial to this view that addiction could be a brain disease. This was a semi-structured study, so we did qualitative interviews. I won't go into too much detail, but these were some of the themes that we were trying to look at. Was what support there was for the brain disease model, what they thought the impact might be on people's treatment seeking, so whether it undermines their belief in their ability to choose not to use drugs, as well as what sort of clinical treatments will be most effective. And when we looked at just this, and this is a very small sample, so we have to take this study with a grain of salt. Of the 30 individuals, only 10 strongly supported the brain disease model. One guy said something like, I think it's overwhelmingly helpful because people generally need some explanation that is reasonably scientifically based. However, 25 were either negative or ambivalent about the brain disease model. They said things like it was seriously flawed, it's simplistic, or that it could be a double-edged sword, meaning it could have positive and negative implications. When we divided this by whether people had any clinical experience, you can see that only 4 of the sample of clinicians supported the brain disease view. It was mostly the non-clinicians, so the animal model researchers, so people who had no exposure to drug addiction. So in contrast to this view that this sort of brain disease view of addiction is uncontroversial, our small study suggested that there is in fact quite a bit of concern around the brain disease model. We're currently looking at conducting an international survey where we're going to be looking at clinicians and AOD workers in a number of countries, so the US, UK, Canada and Australia, to see how prevalent this sort of support or not support for the brain disease model of addiction is. And it may just be that this is, maybe Australians are a peculiar breed. Maybe if we go to the US, there'll be a lot more support where this view has been spoken about a lot more strongly, and where 85% of the research that's done in addiction is funded. So if we did assume that addiction is a brain disease, how useful would it be to think of it like that? What might be some of the potential advantages or disadvantages? So some of the I guess, the promises of addiction are mostly therapeutic. Through neuroscience, we'll develop more effective and rational drug treatments, so drugs that target the deficits in brain function, more specifically with fewer side effects. Might be able to develop vaccines to prevent drug addiction. Neurosurgical cures, where we can use brain stimulation to actually alter brain activity. I'll talk a little bit more about that. Maybe possible to use diagnostic technologies such as genetic screening or neurocognitive testing to try and better match people to treatment. So find those who are more likely to benefit from a particular pharmacological treatment or a different psychotherapeutic intervention. Or even predict those who are more likely to develop an addiction before they actually start engaging in drug use and trying to intervene earlier. Despite about 30 years of research, we've seen almost no movement in this area, as we don't have any good genetic or cognitive testings that are routinely used clinically to try and better match people to treatment. There is some evidence around things like the naltrexone and the opioid receptors, where we might be able to identify those who are more likely to respond to naltrexone for alcohol dependence and opioid dependence. But in generally, most of the treatments that we currently use are the older drugs, so the substitution treatments. Then there's the potential policy payoffs. So the other advantage of this sort of brain disease, or the great selling point or justification for the brain disease view of addiction, was that it would increase people's acceptance that it was a real disorder that should be treated therapeutically. This would increase funding of addiction research and treatment, and also drive access to treatment that people wouldn't otherwise receive. There's also a hope that by convincing the public, who are generally sceptical of this sort of view, that if addiction is a real disease, that might reduce some of the punitive responses, so less reliance on prison as a deterrent, and reduce some of the stigma and discrimination that we currently see with drug addiction. I'm sure you're all aware that drug addiction is one of the most stigmatised conditions of the psychiatric conditions. Unfortunately, this has been also pretty much a failure. There has been an increase in funding of addiction research, particularly if you're a neuroscientist. But in terms of increasing access to treatment, it hasn't really made much traction there. The prison incarceration rates haven't reduced. California's seen a slight drop in the number of people incarcerated for drug offences, but this has more to do with the fact that they can't afford to keep so many people locked up in prison, and not so much the brain disease model. And also, there's evidence to suggest that calling it a brain disease may increase stigma and discrimination. So if you tell someone that they have that someone's behaviour is due to changes in their brain that they have less control over, they're a more dangerous person. They're more to be feared, and so it may actually increase stigma. And there is some evidence to support this. There was a large social survey in the States which looked at attitudes over a 10-year period, and during that 10-year period there was a significant increase in the support for brain disease explanations of alcohol dependence. But during that same period there was actual increase in stigma and discrimination as well. So it might be that by telling people it's a brain disease might actually increase stigma. Unfortunately, there's very little research that's been done now to really tease out what impact it would have. But we certainly can't assume, as I guess the proponents do, that it's going to have a positive effect. So I'll just quickly look at some of the potential policy downsides. So if we do think of addiction as a brain disease where people have been hijacked by the drug, this could actually imply that they have limited self-efficacy or less capacity to refuse a drug or to change their behaviour. You could argue that it'd be surprising that people actually ever recovered from a brain disease if they've been completely hijacked by the drug. It could lead to a number of possible policy simplifications. So it could focus on medical responses. So if the source of the problem is the brain and the way the brain function is, we should be intervening there. It may actually drive attention away from social policies that we know to be effective in reducing drug use across the population. It could also justify the use of more risky treatments to treat a diseased brain, such as deep brain stimulation, and I'll talk a bit about that. It could also be used to justify the use of coercion. So if people have less capacity to control their drug use, we should be treating them against their will for their own good, and we're seeing evidence of that already. So if we look at some of the policy simplifications, by thinking that addiction is a brain disease, this could give priority to treating those at high addiction while ignoring some of the sort of more population-based strategies to reduce drug use, such as taxation, bans on advertising, and regulations on where people can and can't consume drugs, particularly the illicit drugs. It might also focus attention on addiction, and we know that particularly around alcohol, a lot of the harm comes from non-addictive alcohol use, such as people binge drinking, getting behind a car, getting into violence, and things like that. The overemphasis on neurobiology as a cause of addiction could potentially undermine some of the social policies that we have to try and address the drivers of addiction, such as poverty, lack of education, exposure to drug use. While the overemphasis on the neurobiology of addiction as a cure might undermine psychosocial, so cognitive social supports to reduce drug use, as well as population level approaches. We know that the industry that sell addictive commodities tend to be very favourable towards this brain disease or neuroscience view of addiction. We know the tobacco industry has a long history of trying to use science to suggest that the harms aren't due to their product, but due to the genetic makeup of an individual. And there was a lot of research in the 50s that tried to suggest that lung cancer was due to people's genetic vulnerability and not due to cigarettes, which is obviously something that is good for them because that means that they can sell more of their product. Interesting, I actually got contacted by a lawyer for the tobacco industry yesterday wanting to write a report on the neuroscience of addiction and how that contributes to addiction vulnerability. So they're also moving into the neuroscience space. The alcohol industry, similar, has had a history of trying to suggest that problem alcohol use is something that is a problem of just a minority of individuals. If we could just identify those vulnerable few, the rest of us could drink alcohol with impunity. So why should we punish the many why punish the many for sins of the few? And similarly, the gambling industry has started investing heavily in genetic and neuroscience research, trying to influence policy to restrain addictive gamblers. I'll talk briefly about a couple of these, because I can see we're running out of time. There's been some recent push towards using ablative neurosurgical procedures to treat addiction. I won't go too much around the history, but there is a long and dark history of the use of neurosurgery in the treatment of addiction that goes back to the 60s and 70s. However, in the 2000s, several hundred Russian and Chinese individuals were treated for opioid dependence using neurosurgery based on the argument that their brains were diseased. There were initially positive outcomes. However, after sort of a 10-year follow-up, it turned out that many of these people had relapsed and with some significant side effects from the treatment. The great new hope is deep brain stimulation. So you guys are aware of deep brain stimulation. It involves inserting electrode into the brain. It's used mostly for motor disorders. It's quite commonly used for Parkinson's. About 100,000 people have been treated with deep brain stimulation. Now there's a sort of increased enthusiasm for using it for treating psychiatric disorders. So there's some trials using it in depression and OCD. And there's been a few individuals who've had DBS used for the treatment of addiction. We did a review of the currently available evidence, or the evidence that was currently available in 2012. And there was some evidence of effectiveness, mainly from animal studies, which found that deep brain stimulation reduced their self-administration of drugs. There are also promising reports from patients who've been treated for other conditions, so Parkinson's patients or people who've been trialed for depression, who may have had a comorbid addiction, and they found out that the deep brain stimulation reduced their drug use. And on the back of that, there's been about 5 individuals worldwide that we've identified who've been treated specifically for drug addiction, and they did see some initially positive outcomes as a result of this, so it reduced their drug use. As with the neurosurgical studies, there's a number of caveats around these. These are really small studies, so 1 or 2 individuals in highly selected patients. So if you're willing to undergo deep brain stimulation, you have to have tried every other sort of treatment, and you're going to be in a state where this is kind of your last hope. So you're going to really believe or hope or want this treatment to work. And without a controlled condition, which would be ethically problematic, it's hard to really disentangle what could just be a treatment effect or a placebo effect. There's also a problem of publication bias. So we've got a case report of 5 potentially positive outcomes. You only need a couple of cases that don't get reported to really skew the evidence. And we know that one of the people that were who was treated were treated for anxiety. So that was the primary reason why they underwent deep brain stimulation. The deep brain stimulation had no effect on their anxiety, but it did reduce their comorbid alcohol use. And we heard about that study because of the positive benefit. You wonder whether we would have heard about that study if it didn't have a positive impact, because we only tend to hear about the positive studies. So that's a real issue for the deep brain stimulation field. There's a number of opportunity costs around deep brain stimulation. It's really expensive. It's about $50,000 for the surgery and $10,000 every few years. And in a climate where there are very strict, underfunded, people don't have enough money to get people into the currently available treatments, this has got to have an enormous impact on our ability to treat people with conventional treatment. So there's going to be some opportunity costs. Likely to see this would reduce the number of individuals who'd be treated, and would also impact on the use of deep brain stimulation for other neurological disorders, because you've got a finite number of physicians and teams who can do this surgery, so it's got to have an impact elsewhere. Just in the interest of time, I might skip over because I wanted to get onto the medicalisation of addiction. So what impact would telling people that they have a brain disease have on an addicted individual? Their belief in their ability to overcome their addiction, to stop using drugs, and how they view themselves. People have suggested it may have both positive and negative effects. So the people who are enthusiastic think that it will increase treatment seeking and compliance. So if they think, okay, this is a medical problem, I'll come forward, I'll get treatment. And there is some evidence to support this. We know that people that think that psychiatric disorders are a character flaw are less likely to come forward for treatment. However, there are those who think that it may have some more negative impacts. That by telling a patient that addiction is a brain disease, they may think that it's less curable because it's written into the wiring of their brain, and that it's less treatable. And as Simon Chapman has argued quite convincingly in the area of smoking cessation, that this may actually reduce people even trying, or trying without assistance. And for the case of smoking, we know that most people who quit unassisted. And again, there's some evidence to support this. Psychological explanations of mental illness are seen as being more curable and less debilitating, whereas brain-based explanations were seen as being harder to overcome. So we asked, in our qualitative study of addiction clinicians and neuroscientists, what they thought, what their experiences were about the impact of brain disease explanations on their patients. And again, the views were mixed. So there were some who felt that it would facilitate change. They felt that it gave their clients greater insight into what they were going through. It helped to make sense of the situation, why they were experiencing some treatments, why they needed to abstain, why they needed to avoid certain places and triggers. They felt that it also removed some of the guilt and self-punishment that we know is an important driver of drug use. As one person said, it means I'm not a bad person or a weak person, I'm not morally bad. It means that there have been some changes in my brain. And the others thought that it would actually create optimism and be a motivator for people to go forward for treatment. And again, there were those who were less enthusiastic. They thought that it could lead to, I think, called fatalism. Basically, it's in my brain, there's nothing I can do about it. I can't control what's happened in my brain. As one person said, my brain's stuffed, although they used a more colourful word. It could also lead to learned helplessness. It's a disease that you're always going to have, and that would give them a sense of helplessness or pessimism about outcomes, and would also remove some of the responsibility from actually making the effort to overcome or get out of their situation. And just finally, I'll talk very briefly about coerced treatment. So there has been a growing use of brain research to argue for compulsory treatment programs in a number of countries, including Australia and recently in New Zealand. Coerced treatment comes under a few different forms. We've got compulsory treatment, which is usually used to protect the public welfare, so putting people in, I guess, narco prisons to protect them from harming other individuals. And this was the model that was big in the mid part of last century in the US. And there are a number of other more less punitive compulsory treatment programs, such as ones run in Sweden. The other justification is paternalism. So this is treating people for their own good, which is more conciliant with the brain disease view. So basically helping people for their own good. While the brain disease model is consistent with this view, these sort of coerced treatment programs preceded. And so these sort of programs are like the drug courts that we see. And we have these in New South Wales and Victoria, as well as the Northern Territory Mandatory Alcohol Treatment Program. And this is where people are offered treatment as an alternative to going to prison. So they've committed a crime and they're given the choice, okay, you can go to prison or you can go into treatment. And there has also been some cases of the compulsory use of naltrexone implants in the States. So these are the implants that get put into people that last for several months, and people have been forced to undergo insertion of these naltrexone implants to treat their opioid dependence. The argument is that the autonomy of these people are so impaired that society has the right, actually has the obligation to intervene for the good of the individual. As I've kind of gone through in our review of the evidence, we don't believe that the majority of addicted individuals fit the criteria for compulsory treatment. They're not hijacked by the drugs. Many do still maintain an ability to choose not to use drugs. There's also concerns around the efficacy of many of these programs. The Australian experience is that many people relapse when they come out of treatment, and in the case of opioid dependence, this is quite a concern, given that a newly abstinent person has twice the chance of overdosing. The strongest ethical case comes from the drug courts, where people are offered treatment as an alternative to a crime that they've committed, usually excluding violent or sexual crimes. For these programs, though, it's important that the motivation is therapeutic and not punitive. There has been a tendency for these programs to operate in a way where people are not given access to the most effective treatments, probably more so in the States than in Australia. People wouldn't necessarily get access to opioid substitution treatment programs, which we know are the most effective. And so giving people a suboptimal treatment is highly unethical. You wouldn't see that for any other kind of medical condition. So I quickly just want to finish on a possible way forward. So in giving neurobiology its due, we should accept that drugs act on reward systems. That chronic drug use can produce persistent changes in the brain, and it's important to say persistent, not permanent, because we know from the neuroplasticity that many people can recover. And that drugs are not ordinary commodities, and we should be regulating them in ways to restrict or to ameliorate the use or the harms. And this might have interesting implications for food addiction. So in obesity, there's a growing view that some forms of obesity may be a food addiction. Should we be regulating sugar and fat in the same way that we regulate alcohol and tobacco? Importantly, that treatment may be needed to address these changes, and that there are biological differences in individuals that increase people's vulnerability that need to be taken into account. However, in giving neurobiology its policy due, we don't have to accept the simplifications that addiction is best thought of as a chronic brain disease, that high-risk medical strategies are necessary or going to be the most successful, or that biological interventions are routinely required. We also don't need to accept that coercion is an effective or ethical way to treat people with an addiction. We should acknowledge that addiction is a highly variable. Majority of people don't fall into this category of a sort of more chronic relapsing condition, but there are those who do, and for those we should be giving more intensive support. But importantly, we should be maximising their autonomy rather than overriding it and saying, well, they have no control over their choices. Just quickly, if anyone's particularly interested in this study, we're running a qualitative study of the views of the AOD sector in Victoria. Tony Barnett, the PhD student here, is looking after this study. So if you're interested in this, want to find out any more, please come and see me or see Tony afterwards. And just acknowledge the Neuroethics group at Monash and other collaborators and funders. Thank you very much.